afternoon. So can everybody hear me okay? All right, good. So my son told me that I am the closer, so don't screw it up. So I'll try not to screw it up. You should always know people's conflict of interest. So I do a bunch of research for novel therapeutics in patients with idiopathic pulmonary fibrosis. I really don't think there's any conflict here, but I am also the medical director of an organ procurement agency, Sharing Hope in South Carolina. So I'm going to share some of my perspectives from that standpoint as well. So I always like to start out with a take-home point so that you can kind of sleep, and then you can wake up at the end and you'll be good. So referral timing. Early is still better, and I'm going to talk a bunch about this. I think that the challenge with the referral timing, there are definitely things that make it difficult. From our recommendations as a transplant society, and then some of the things that people have brought out about the heterogeneity of disease. Full evaluation for lung transplant, it really does take time. You can try to jam it all in really quickly, but I will tell you as a transplant doc of more than 15 years, the folks who have to go through it really quickly, I think are definitely not as prepared as individuals who we have a chance to build a relationship with. Listing for transplant, this is highly variable and definitely depends on where you are. And then lung transplant is cool. All right, so lung transplant. So the goal of this was to talk about the evaluation, not to teach you everything that there is about transplant. So I just want to do a quick look. I'm totally focused on the US experience, not the world experience. So this data that I'm going to show you is all UNOS data, so the United States. So some of these graphics are a little hard because they don't put the diagnosis name on there, but I will just tell you that Group D in the United States is all interstitial lung diseases, and the vast majority of the patients with interstitial lung disease that are transplanted in the US have IPF. So this graphic, what it shows is that the number of transplants is steadily growing over time. From 2004, this Group D, we're doing a lot more of them with ILD. And the total, if you add up each one of these lines, in the United States, we do a little bit over 2,000 lung transplants a year. Patient survival, so I opted to choose based on age. All of these graphics, if you go and you try to find what is the survival of patients based on diagnosis, they're confounded by their other medical conditions. So in other words, their other medical conditions also contribute to how they do. As a general rule, individuals with IPF are older, so one way to get a really clear-cut look at how patients do with a lung transplant with IPF is to kind of take the average IPF patient, which is generally in their 60s, probably over the age of 65 at this point, and how they do over time. So the average survival for all comers is about 5.5 years. So the average means if I transplant 100 patients today, if I could teleport in the future 5.5 years, then there would be 50 folks still left alive. So a lot of times people will come in and they think that they only get 5.5 years out of this. No, that's the average. So we definitely I have patients that are more than 20 years out that I take care of. Individuals who are over the age of 65 are the brown line, and the brown line, the 50% mark for them is right around this 55 months or so. Okay. So what's the benefit of doing the transplant? Well, we do a lot of really good things. We get rid of supplemental oxygen. We get people living independently. So if they had limitations before, we get them so that they can do their activities of daily living. So that means all the fun things like washing the dishes, cooking their food, cleaning their clothes, those kinds of things. We do get a bunch of people exercising a bunch, but really and truly when you look at the average outcome, we're talking about giving people independence with their usual daily living activities. Transplant, absolutely, for the individuals who are selected to be transplant candidates and undergo lung transplants, they clearly get a survival benefit. So in other words, transplanting them does get them to live longer on average. Unfortunately, it is a highly select population, which I'll talk a little bit about. And then this one, I purposely blasted in last. Unfortunately, comorbidities absolutely come along with doing lung transplant. There's a clear upfront risk. Most of our patients we don't think are going to die in the next 30 days. Anytime we operate on someone, there's an inherent risk that they can get profoundly ill and end up in the ICU. Deconditioning is a very real aspect of the medications and transplant itself. So rehab after the transplant, you really are, it's not a week. This is a 3-month or a 6-month procedure. A common thing for patients to say to me is, I thought I was doing better at a month, but man, and they're talking to me at 6 months, wow, I'm doing so much better, which is really true. Acute kidney injury is extremely common early after transplant, as high as 90 to 100% in a bunch of series. In my center, it's probably close to 70 to 80%. And then their kidneys recover, but unfortunately I give them immunosuppressants and toxic medications so that over the long haul, chronic kidney disease is a very real aspect of this procedure. High risk for rehospitalization in the first year. More than half of the patients are readmitted in the first year. Hopefully it's for something quick, but it's a myriad of things that can get folks admitted to the hospital. High blood pressure, diabetes, complications of the immunosuppression, including increased risk of cancer, and then unfortunately the #1 cause of long-term death after a lung transplant is that the lungs get small airways disease, which is very similar to COPD and emphysema. And so folks will get short of breath, they end up on oxygen, and then they can succumb to a respiratory illness. So those are the downsides. But overall, I would still argue that for a select group of patients, this is a really good thing to do. So when we go out into the community and we start talking to our pulmonary colleagues and we say, when should you send the patient? The guidelines that we wrote said anybody with a diagnosis of UIP or IPF, a definite IPF patient, or fibrotic NSIP, regardless of their lung function, anyone. Abnormal lung function in the interstitial lung disease cohort, so folks who have a forced vital capacity less than 80% or a diffusing capacity less than 40%. Any dyspnea or functional limitation attributable to lung disease. It really sounds like anyone is what we wrote in this guideline document. Any oxygen requirement, even if it's only with exertion. And for the inflammatory lung diseases, if you don't have a clinical response to the anti-inflammatory medicine we give you, you should be coming to a transplant center. So, do we actually do that? Is this what our pulmonary colleagues are doing? Are they sending all these patients to transplant centers? So I'm part of the IPF Pro Registry, which is a collaborative effort between the DCRI, Beringer, Ingelheim, and a bunch of academic centers where we have a registry of patients that we are enrolling. It's an observational longitudinal registry, so we're following over time, very similar to the PFF registry in that way. They have to have a confirmed diagnosis of IPF. And we had, at the time from this data collection, it was 18 centers. There's actually more centers now. The first patient was enrolled in June of 2014, the last in May of 2016. And from this cohort, there were 334 patients that were enrolled. We pulled out a bunch of people that we said we used really broad criteria for what made you not eligible. So if you're over the age of 75, we said, well, you're not eligible. If your body mass index, if you were very overweight, we pulled you out. If you were actively smoking, interestingly, there were only 5 of those out of the 334 in the registry. It's really good. It means a lot of people quit. We came down, we had 226 potential people eligible for transplant, and then we said, well, let's use the tighter criteria. Let's just say that referring docs are like, no, I think that you should be a little sicker before I send you. So let's just look at the forced vital capacity less than 80, a diffusing capacity less than 40. We had some missing data, so we excluded a few people. We came down to, out of this 334, there were 176 that were theoretically eligible to be referred for transplant. So how many of them actually got transplanted? About a quarter, less than a quarter. So what is going on? Something is going on. So we are clearly not referring all these people. Now there are a bunch of potential reasons for that. But I think that one of the reasons is what the transplant centers do when they get the referrals. So when I look at a patient, who's my ideal referral? My ideal referral is someone I'm talking to right away about, let's figure out how to get you on the list, let's get you through the system, let's make sure you're adequately educated, treated, good, and then let's get you on, right? So that's a patient who is high risk for death over the next 2 years, has a poor quality of life, can't do their ADLs, they need assistance, but they are not so sick that I'm worried that they're going to do poorly with the surgery. And then I also really want them to have a really great social support system, that they've got insurance and money and resources, and they can relocate to Charleston, and we can do the transplant. And if they don't meet these criteria, then I will send messages back to the referring doc, whatever those reasons are that they're not ready for transplant. So why don't we just tell the referring docs what it is exactly that we want, so that we only want them to come when they get listed. Well, that's problematic. So you all have seen this one a few times now today. So we have patients who kind of perk along. We have patients who rapidly decline, like we just heard about, when they get to the center. And we have patients who do okay until they have their exacerbation. So we have to do a better job of making sure patients know about transplant to account for this. And to emphasize that, particularly for the physicians that are in the room that are seeing these patients, this is now, it's amazing to me that this is now an old paper, but it doesn't get mentioned a lot anymore, I think because it's, you know, more than 10 years old now. So this is a paper of 168 patients that were randomly assigned to the placebo group in the gamma interferon trial, one of the earlier gamma interferon trials. And they looked at how did they do? What was the natural progression of disease? So this is in the era before pirfenidone and nintedanib, so hopefully we're doing better now, but I do think that some of this applies. So the patients had to have progression of disease. They had to have lack of improvement despite a lot of prednisone. And I still think today that when patients progress, prednisone is given to an awful lot of our patients. So I think that this is actually maybe reflective of a lot of our patients that get referred to our ILD centers. They had to have a fairly preserved forced vital capacity, but their diffusing capacity could be severely reduced, and they had to have definite IPF. So in this particular cohort, the mean age was 64. The forced vital capacity was about 65% predicted, DLCO 40%. 60% of them had a confirmed biopsy. That's a little unusual. It's probably flipped around now at this point for most of our series. 83% of them, though, had a clear CT scan that looked like, yep, we were totally convinced. And again, these are folks that did not respond to prednisone. So if anything, I would say that this is a very, very convincing cohort of IPF patients. And about a third of them were using supplemental oxygen. So these spaghetti plots, I put them up here mainly to show that as we are following patients in clinic, we like to look at PFTs. We like to look at 6-minute walk tests, and we like to talk to patients too. You have to integrate all of that. If you look just at the PFTs, these are the pulmonary function tests of patients who actually passed away. So if you take like this guy up at the top here, and I'm assuming it's a guy, so he's pretty stable. PFTs actually get better. Hey, everything's great. You're doing okay. And then they kind of fell off. There's a bunch of patients in the middle here that where their line ends, like this one, the PFTs were actually getting better, quote unquote. And then something happened to them and they passed away. So looking at PFTs, I think, is very, very difficult. I think looking at patients in the clinic and asking them how they're doing is also sometimes really difficult. So the conclusions of this paper was that there were about half of these patients who had fairly rapid declines in their clinical course that were not very easily predicted. I still believe that this is a very real phenomenon. Unfortunately, this has not gone away. So if we're going to offer transplant to people, we really have to be ready. We have to be able to offer them a salvage therapy if something happens to them relatively quickly. So to me, that is the biggest argument that, in fact, I really do want you to send me your patients when they're diagnosed. So the gap index, this is much later, first published in 2012, and then there was a subsequent paper to this that added in had you been hospitalized within the last year. But this is a fairly good scoring system that again tries to tackle which patients are at greatest risk for death, and those with the highest score, their risk of death in the first year is about 40% of those patients. So that's a really high risk group. The flip side of that is, yeah, but 60% of those patients don't go anywhere in a year. So maybe we don't need to transplant them tomorrow. These things, I think, are very, very, very difficult. So what does the transplant community try to do? Well, we are trying very hard to list those that we think it's reasonable to have an upfront surgical mortality from. So we will look for patients who have a clear drop in their PFTs, a clear decline in their diffusing capacity, and clearly are doing poorly on their 6-minute walk test. They either have an acute decline or they got hospitalized, something that really changes. But if they get sent to me at that time, it is very hard for me to get the workup and everything else done that I'm going to talk about. We also do pay attention to how their heart is functioning, their right heart. So community pulmonologists will often say back to me, but I just referred a patient to you that had this gap 3, they look like they're sick to me, and you just sent them back and you said they're too early. Well, that has everything to do with how individual transplant centers decide to manage their list. So the next section of this is just talking a little bit about how transplant centers do things. So this is again US data. These are the percent of patients that are transplanted based on how long they're waiting. So if you look at the purple line, it's a little bit less than 50% will get transplanted within 3 months of the time they get put on the list. And this is from 2014. 15 and 16 are very similar to this. If you look though, this says 10 years on this one, but 5 years. So back to late 2011 or so, there were actually people that were on the list for 5 years. 3 years, fortunately that line has vanished. 1 year is most patients get transplanted, but that's 70%, so a third are not. So a third of the people on our list are sitting on the list for more than a year. So you can get, if I think that I've got a list and I need to put you on and you're going to hang out for a year, I might put you on earlier. My list, we're the 5th fastest transplanting program in the country. If I put you on the list, you better be ready for a call tonight. So we have a very different strategy. Why do these different centers have different strategies? It absolutely has to do with how many donors are available in their region. So the more dark the box, the better. I'm in South Carolina here. We kind of have a shade in here. But around us, there's a fair number of organs that are available, and we're willing to travel to go get them as well. So in this particular graphic, this is who actually gets 100% of their patients transplanted in the first year. That's the dark green box. So you'll see this state right here, which is where I think we are, if I'm not geographically challenged. North and South Carolina. Up here, this is a big problem area. There's a lot of people that live up in there, right? So one of the things that we often discuss at UNOS is how can we better allocate organs. It is hugely complicated, not an easy topic, but it does matter where you are listed. That is a truth of the system. So then the next thing I get is, yeah, but come on, Tim, seriously, you don't want to see everybody, do you? Well, I don't. I don't want to see everybody. I'm happy to talk to everybody, but it'd be really hard. In the United States, the estimates are that there are somewhere between 3,000 and 10,000 new cases a year of IPF. It's really hard to pin that down. But if you imagine that it's in the middle of that, you're going to overwhelm every ILD center really quickly and every transplant center. So the absolute contraindications to transplant, there are a bunch. It basically boils down to if you have significant other organ disease, if you have a malignancy in the last 2 years, depends on what kind of malignancy, though, right? Prostate cancer is really different than ovarian cancer. If you have an impaired left heart, that's hugely problematic. Patients do not do well at all with systolic heart function issues after transplant. And then the non-curable extrapulmonary infections I left on here, and I left it because it depends on what center you are. That might be an absolute, but that is not everywhere. So age. Folks often want to know about age. So age greater than 65 years in association with a poor physiologic reserve, or frail, if you're frail, then folks are going to say no. There really is no upper age limit, but generally speaking, and this is still true in the United States today, if you're over the age of 75, you're exceedingly unlikely to be eligible for a transplant. And now we have treatments for hepatitis C, HIV has been transplanted. So if you're at a center of specialty interest in those things, those might be relative contraindications, not absolutes. So really what this comes down to is having a good relationship with those referring docs and making sure they know what your center is interested in or not interested in. So I'm going to talk a little bit about age, and then I'm going to finish up with a little story too. So age. So it's clear that we are transplanting more and more patients over the age of 65. So if you look at the total for last year, it was about 30% of transplant. If you look at where we are as of the last data drop, I pulled this last night, and I think the data drop is from 2 weeks ago. We are at about a third of the patients in the United States right now are over the age of 65. So it is definitely becoming more common. So what can patients do and what can referring docs do to help out? Well, we want to prep you for what you can expect. We want you to take care of all the things that the transplant center requires, and we want you to modify risk factors that can affect that transplant outcome. So what can you expect when you go to the transplant center? Well, there's a couple different ways that folks do things. It can be an initial visit. This is what we do at MUSC. We've tried to do kind of the full evaluation. We managed to scare the daylights out of patients, and they ran away and never came back. So we changed. We have you come for an initial visit. We talk to you. We tell you about it. And we say, hey, what do you want to do? Other places will do like a mini evaluation, which is like a 2-day visit maybe. They do a bunch of tests. They talk to you, and they say, hey, what do you want to do? That full evaluation is 4 or 5 full days of testing, blood work, imaging, breathing tests, organ-specific testing, of all sorts. You meet with every kind of consultant you can imagine, and the selection committee meets at the end of that and talks about whether you're a candidate or not. Every single transplant program is interested in cancer screening being fully up to date. This does not require a transplant center. Your primary care doctor can take care of this. So make sure you saw your dentist. Make sure you got your colonoscopy, your mammographies, your GYN exams, all that stuff. Osteoporosis assessment and management is hugely important. So many of our patients have received lots of prednisone, even if I don't think that they should have. Many of the patients have gotten it, so bone disease is a real issue. And then just management of the medicines are other things that our community colleagues can help us out with. There's no question that corticosteroids increase the risk of perioperative complications in the COPD population. They probably do it in the IPF population as well. Multi-drug immunosuppression regimens, you really have to weigh the risks and the benefits of that. And in IPF in particular, it looks like that stuff is harmful, not particularly helpful. And then, without a doubt, all of these medicines that folks are taking have associated morbidities. 6-minute walk test, it's clear that if you walk farther and if you're in better shape, you're going to do better with transplant. You know what? You're also going to feel better. So 6-minute walk testing and distance is a great way to tell our patients they really need to go to pulmonary rehab. Every single transplant center has a requirement for patients to go to pulmonary rehab. Get signed up for pulmonary rehab if you're interested in transplant. Obesity is another big thing that folks talk about. Obesity definitely increases the risk of early complications. In the latest registry data, it looks like that washes out at 1 year, but that's in a highly selected group of patients who are bigger because of this older data that changed our behavior. And in fact, in IPF, being overweight is also bad for your 1-year risk of death. So lose some weight. You know what? It will make you feel better. You'll do better on your 6-minute walk test. All right. Transplant's really expensive, so we have to prepare you for the cost. Fundraising, asking for help from everybody, these are all good things. Relocation, you have to relocate to the transplant center if you don't live right down the street from it. And the caregiver is also giving up a chunk of time that we often don't really address very well at all. So they often are taking leave from work and giving up that income. And that can have a huge impact on our caregivers besides our patients. So I'm just going to finish up with the why transplant is cool, okay? So this is a gentleman that I saw, and and Dr. Whelan actually took care of him too. I see she's talking later in the tomorrow, I think. She started seeing him in 2007. He had really good lung function. His forced vital capacity was 3.8 liters. And she followed him over the years. He presented with polyarticular joint disease, and then that went away. He never had that problem again, but he was short of breath and had bad ILD. He got treated with tons of immunosuppressants, including N-acetylcysteine. He got all sorts of good stuff. I met him in 2010 when I moved to South Carolina, and I said, you know, you're still doing okay. We're trying these medicines out. Let's see how you do. He kind of did okay in 2011, and if you look, so there was a big drop, 2009 to 2010, but he was stable, he was exercising, he was definitely requiring oxygen when he was exercising, but the PFTs, other than that one big drop, it looked like he had stabilized. We evaluated him for transplant in 2010, and I followed him very closely. We actually listed him for transplant, and within, I think this was day 14 of being listed. On the day that we listed him for transplant, he felt really good. He was being stable. He unfortunately developed acute exacerbation. He lives in my town. I followed his ambulance over the Ravenel Bridge to the hospital. We admitted him to the ICU, and that night we got an organ offer, and we transplanted him. His chest x-ray got a lot better. This is his chest x-ray from maybe a year ago. He's now 6 years post-transplant, and he's living his life. He actually does run, and he likes to joke that he wins. He's often the only guy in his age group as a out. But he does win races, very active in the community, feeling awesome. Truly an amazing story. So, early referral, got to do it. You got to get your transplant centers. If you're worried about a patient, you got to tell us. If you're worried about someone, we're going to listen to you. We'll see them sooner. Age greater than 70? 70 is one of those tough ages for me personally. I definitely think that there are patients who are in their early 70s who can be good transplant candidates. Oftentimes, they're maybe too early for transplant. So that's a juggle that we really struggle with. I think it depends on the individual center. The transplant evaluation, because it does take time, you got to refer them early and really prepare them. Get all that health maintenance and screening and pulmonary rehab done. Get your weight down. Plan for that impact. That impact is very big. There is no transplant recipient who gets through this thing without any kind of bumps. So that is a very, very important thing. And then transplant offers a second chance for the right candidate. And it is very cool. So thank you very much. So for the folks in the other room, since I was sitting over there, I know they couldn't hear you. So the question was, 2 lungs or 1? So in the United States right now, about 80% of the transplants that we do are bilateral transplant. So it is definitely a much more common procedure. As a general rule, the single lung transplants tend to be the older patients. So if we look at the registry and we say, who gets those single lung transplants, it does tend to be the older IPF patients.
Does anyone else have any questions?
Sure. So the question was nintedanib and pirfenidone prior to transplant. So I think most transplant centers have a similar approach. I'll tell you what we do. So pirfenidone, the half-life is really short, so we don't really worry about it at all. Nintedanib, with the potential on bleeding and what kind of things it can do, what we will do is we will get an organ offer. So programs often know about organ offers probably about 48 hours before the actual surgery starts, somewhere in that neighborhood. So if we get an organ offer that we think looks like it's good, we call our potential recipient, we say, we're not calling you in but don't take your nintedanib. Some other centers are more nervous about it, but I think as I talk to colleagues, I don't know if there's any other transplant folks in the room, but I think that that's a pretty common approach. Yes, ma'am.
I live up. Oh, okay. Oh, thanks. I live up in the Northeast, that very light-colored area of your map, and some of the transplant centers in Massachusetts will tell us that our patient has to be within 3 hours, and that is not possible for some of those folks. Is that typical? Just that parameter?
Typical. Typical is a hard word.
Is that what you do at your center?
No, that is not what I do at my center. But so I was at the University of Minnesota before I relocated to Charleston. It's a little warmer in Charleston. So at the University of Minnesota, we had patients who were waiting, you know, in South Dakota, North Dakota, and if they had a flight plan and could get to the center in a timely fashion, we were okay with that. And we covered such a large geographic area. So some programs do it differently. We are okay, so we have Atlanta as a potential for us, and we're willing to have people live in Atlanta and get listed at our center because folks will dual list. So we do that. Duke, I'm not picking on Duke, I'm just stating how Duke does it. Duke makes everybody relocate to Raleigh-Durham, and you do rehab there, and they really do a very labor-intensive interaction with their potential recipients, which I think is very cool, but very difficult to do for a lot of people. After the transplant, though, for that 3 months after, all transplant centers make people stay local, truly local, like, you know, within a half an hour is the typical what centers will say.
Thank you.
Yes, ma'am. Yes, that's a very astute question. So the question for the folks in the other room was a high antigen level. Does that preclude one from being a potential candidate? So for those of you that don't know, it was brought up with the stem cells that your body won't recognize those stem cells, those mesenchymal stem cells, because they don't have those antigen complexes that identify your body as yours and something else as foreign. So a high antibody level to antigens means you have a lot of proteins that will potentially recognize a donor, and then unfortunately what will happen is that you will reject those lungs immediately. They become immediately not able to function, and you will die. So that is a very bad thing. So the hard part is it's not really an exclusion for transplant. It's not that we're excluding you because you have that. It becomes an exclusion because it may not be really possible for you to get a transplant. So in other words, there may not be any potential donor for you. So we could put you on the list, and you'll just sit and you'll wait. So for my center, we had a patient who had a 99+% antibody level to all donors out there, and we dual listed with Cleveland, and both us and Cleveland said, well, we'll put her on the list, she's just going to stay there. That might be some of those people who are on the list a very long time. We were very fortunate. She got transplanted, and she's doing well today. So it's not a real absolute contraindication, but there are many centers that will say, you know, there's not a value in trying to put you on the list. You can have a follow-up. Mm-hmm. Probably, maybe not that protocol, but a similar protocol. So the question for the folks in the other room was, is there a way to maybe lower those levels? It's not clear the efficacy of that, I guess. So yes, Toronto does do it. Other centers do it. We do it for kidney transplants as well. So, but the efficacy of that, unfortunately, folks who have those high levels, they are at much higher risk to develop chronic rejection. So their longer term outcomes are affected by that as well. All right, I'm good. Can I keep going? Is it okay? I don't want to monopolize. Yeah? Okay, all right.
I have a question on living donor lung transplants, and what is your opinion of that, and what is the age requirement on that?
Yeah, so the last living donor transplant that I was personally involved with was in 2004. And the number of living lobar transplants that are being done today, I think, is exceedingly small. The reason is because we changed the lung allocation score, and so folks who are really sick are being prioritized much higher. So it's really made that procedure kind of go away. I am not involved in pediatric transplant, but that's typically who we had used it on. The gentleman that we transplanted back in 2004 was an IPF patient, and he did well for a while, and outcomes are very similar, but it's just not really offered very much anymore. I'm not even sure if there's any centers that are. So maybe 5 in the past 10 years. Yeah. Yes, sir.
I guess the data was mostly for IPF patients. Do you have any studies or any prognosis for the younger cousin NSIP?
Yeah. So the challenge with NSIP is not so much. So there's kind of two challenges. Not all NSIP is the same, right? So we have NSIP that will really respond to medications, and so we're basically talking about NSIP fibrotic, or the really scarred down NSIP. The challenge with that is that it often is coming along with their connective tissue disease. And so folks who have connective tissue disease oftentimes have other organ involvement. And the one that tends to make transplant centers anxious is the esophagus. So if folks have esophageal dysmotility and bad reflux, that can be a rate-limiting step for transplant at many centers. And I would also tell you it is a little bit of a moving target. So I think that if you have patients like that, I would say totally worthwhile to refer them. I see a lot of patients we've transplanted. In fact, in the last 2 months, we just did a transplant of an NSIP fibrotic. So we do it, but unfortunately for that big pool, there are a fair number that get excluded because of their systemic disease.
With the possibility of a rejection, why do you favor double lung transplants as opposed to single?
Man, you guys are tough. Okay, so there's a really smart guy who it's probably, I gotta think about what year it is now, about 15 years ago. So a really smart guy, about 15 years ago, wrote a paper about why we need to put single lung transplants into all our IPF patients so that we have organs for everybody. That guy now does bilateral transplants on all of his patients. So why does he do that? I don't really have a great answer for you on that. I will tell you that as a general rule, if you develop problems in the transplant, it's better to have 2 than it is to have 1. So I think that there's a bunch of data out there about survival, and it does look like that there's some survival advantage, but it's really tough to say whether that's truly the transplant, or maybe we're better at our management of things now compared to some of the older cohorts. But if you get into a problem, one problem is that the airway can stenose. That will typically happen to one lung and not the other. If that's a severe problem on one side, you've got the other side that is kind of your backup. So that's one issue for me, is that I think that it's better in that way. The other issue is that I definitely had patients when we were doing more single lung transplants where the IPF progressed, or they developed complications of that native lung that just ruined their quality of life. But in all honesty, back to the first thing I said, there is definitely some validity to the argument to only do singles still. That is still a truth. And you had a question, sir? Uh-huh. Uh-huh. Yep. So I'll repeat the question. The question was about that donor ischemic time, or how far away can that donor be from a potential center. So it really depends on the individual center's comfort level is the answer to that question. So if we were in Australia, for instance, Australia, they're okay with having 14 hours to get the lung. That is not really the case in the United States. And then the second half of the question was some of the newer technology for perfusing the lungs or giving it, so some of them are blood-based and some of them are not blood-based, but running that through the lungs, is there an advantage to that? And I think you tied it to the ischemic time. So from the ischemic time standpoint, it's not clear that it helps or hurts. It's not really been looked that way. Those machines are often being tested. Can we take a lung that maybe doesn't look quite right to the transplant team, put it onto that rig and manage it on the rig and then feel comfortable that we can use it? And then I think where that will head in the future is that as we get better, maybe like these stem cell discussions or better ways of manipulating what we put into that fluid, we might really be able to make the lung a little bit healthier before we put it into people. So that's still a little bit of ways. Wow, yes.
As a follow-up, As a follow-up to that, how did the Australian transplants fare with the 14-hour?
They're awesome. They are really, really awesome. Like first of all, I really like all the Australian groups. They're friends. They're a real fun bunch of people too. But yeah, their patients do really, really well. So they will say, when we sit around the table at dinner, they'll say, "You guys are wimps. You need to toughen up." Yes, sir.
How do you balance the transplant with kind of the palliative care part we heard about before? My question's about balancing transplant with the kind of palliative care with the limited life expectancy. How do you work well with your kind of palliative care team in that respect?
So, my suspicion is that sometimes we probably fail. Honestly, I think that it's tough. I think that I'm a huge believer in palliative medicine. I think I may be a huge proponent of that because I am an IPF doc. I do transplant, but I take care of lots of patients that I don't transplant. So I think it's a huge and very important component, probably for all of our patients with advanced lung disease. I think where we fail is that we want our patient to be 100% all in, and transplant. So Lorcan, the person's picture I showed you there, like, he's done awesome, and that's what we talk about. We talk about the bad stuff too, but I want you to be focused on the really good things that are going to happen to you, because to get to that, I have to put you through so much, and I have to have you totally and completely in the game. And so the hard part about palliative medicine is making sure that the transplant teams have a good, strong partnership to allow that to happen, so that those two goals can run congruently. Because in some places, depending on who they ask, right, they really start focusing on very end-of-life stuff. And they totally need to be done together, but they have to be done in a collaborative way. And so I think a bunch of places fail in that. And I think you should absolutely comment on that, Kathy.
So I can talk about our experience in Pittsburgh. So we also have a lung transplant program, and we have a she's not new, like over the past 3 years, a palliative care nurse practitioner. And just within the past year, the lung transplant program, that she's part of the workup. And she's their patient as well as, you know, she's on their team. So she addresses really the symptom management, but she, like, I watched her last week with, we had a patient who he had advancing hypersensitivity pneumonitis. And in the office, he's 15 liters and he's 83%. And he thought his disease was going to get better. He lives on a farm, they have birds in the house. But so anyway, he needed to be admitted. He didn't want to come into the hospital. But the physician talked to him and provided the information about, we'll get you in, we'll see about transplant, because he had already been like not evaluated. He was suggested to go. He was the one dragging his feet. So they did a inpatient evaluation. But then the nurse practitioner, what she did was she sat down with him and she identified 3 scenarios. Okay, so the first scenario is, okay, you're in this, if you're going to get a transplant, if you're going to get approved for a transplant, you need to be, all efforts, no comfort measures, like, full resuscitation. So that was the one. And then she said, what if you don't get if they say you're not a candidate? He said, well, then I want to go home. I don't want to go on a ventilator. So she had to develop 3 plans. And it was all like pending this, pending this, pending this. But by the end of an hour of time with him, she had a pulse completed and she had it documented, like all those different things. But it took a lot of time, but it was the discussion so that everyone, including the patient and the caregiver, everyone was on the same page.
And I just to add to that too, that we use our palliative care team after transplant for the family, for the support of the family. We oftentimes kind of forget how hard it is to be a family member who's, hanging around the ICU too much. So we use the palliative care team in our place a lot.
Yeah, and I think you have to see it as rather than an either or, as a both and. So, we all palliate our patients. We try to make sure that they're not in pain, that they're not short of breath, that they're not coughing, and all of that's within the palliative care spectrum. And I think that for our patients, when they're going through the transplant process, there's no guarantee at the start that they're going to end up being transplanted. So I think that we have to have those go hand in glove, understanding that there may be certain decision points where they do have to make a choice of, am I going to go down a more palliative pathway or am I going to go to a more aggressive pathway? But I think that the most difficult thing that I've dealt with as an ILD physician is where a patient and their family become very invested in the idea of getting transplanted, and then they are not going to be able to receive a transplant. And I think that tends to create this kind of dissonance, like we're doing everything and now we're going to do nothing. And so rather than that, I think that to integrate it at the start makes them understand that regardless of what the outcome is, we're going to continue to care for them. We're going to continue to make sure that they have as good a quality of life as possible. So I really would urge that this be a both and.
And that's a phenomenal example of how I think we sometimes can do better. Absolutely. Yep.
We have time for 1 or 2 more questions on any topic.
Not so much a question, just a support of that last conversation. I am a palliative doc, and so I've appreciated that. Just to emphasize, it is a both and, and one of the slides up there indicated that, the discipline of palliative care is to improve the quality of life and, limit the burden of suffering for those with life-threatening illnesses. We've changed that to life-defining illnesses, which I like a lot better. It doesn't have to be life-threatening, just something that has entered the life. And I've had to advocate when we talk about, we don't want to talk about palliative because that means end of life or that's going to soften their stance. I've worked with the CF clinic, and have taken families to the point of transplant where they just said there's no way we want to do that anymore. But just by defining the goals of care and what their values are and what their goals in life are, it can make a huge difference. And so more than just symptom measurement, I agree. I think our pulmonologists are some of the best palliative docs around because of their capacity to effectively treat problematic symptoms. But what the palliative team can really do is really help with that. The other just minor points, I also happen to be someone saddled with a diagnosis of IPF and had my transplant 7 months ago.
Awesome. Definitely cool.
I think that is the perfect note to end this session
Absolutely.
on. So thank you,
Absolutely.
everyone.